Bismillah ar-Rahman ar-Rahim. Let's resume the algorithmic approach to characterization of ovarian masses. We have finished the functional cystic lesions in the ovary and the benign complex lesions and how MRI is needed for characterization of these masses. Then we came to the neoplastic lesions of the ovary. This is the normal, this figure shows the normal ovary by the different anatomical parts from which the origin of the different tumors arise. So we have the surface epithelial cell epithelial tumors, and just today one of my colleagues sent to me a case. It was exophytic mass arising from the surface epithelium. So surface epithelial tumor cells, they are the most common epithelial tumor, the most common ovarian tumors, representing 65 to 70%. The age group 10, 20 and more. It's more common in the childbearing age group. The types: serous, mucinous, endometrioid, and we have also the Brenner tumor and the endometrioid tumor and the clear cell. All these are the surface epithelial tumors. The most common are the serous and mucinous by its spectrum from benignity to malignancy. We have benign, borderline, and malignant. And then the germ cell tumors. The germ cell tumors represent 15 to 20%, more than 25 years old. Mature teratoma is the most common, and we have dysgerminoma mainly in the teenager and the young age group, yolk cell tumor, choriocarcinoma, and embryonal carcinoma. Ovarian stromal tumors, the sex cord tumors, representing 5 to 10%. It can occur in all ages, but it is more common in the older age group. Like the granulosa cell tumor, fibroma, fibrothecoma group are the most common. And then others. What are the others? Like metastasis, we have just give a hint on the ultrasound, the appearance in the Krukenberg tumor and ovarian lymphoma. They are the most common, Krukenberg tumor and ovarian lymphoma. Role of MRI in ovarian tumors. How to reach a diagnosis. To determine the site of origin of a pelvic mass. If we have a pelvic mass, we want to know where is the site of origin. Then assessment of the primary tumor regarding its nature, cystic, solid, or complex. Is it benign, borderline, or malignant? And in malignant masses, we have to see the extra ovarian spread. What is the pattern of the extra ovarian spread? So let's start to see this image. In this case, we have a large pelvic abdominal mass. In this case, we can say that it is a pelvic abdominal mass because it is large. But in the previous case, if two masses like that in the pelvic or in the true pelvis or false pelvis, it is adnexal masses. But this is a large pelvic abdominal mass, complex, cystic and solid, with 6 septations, vegetations seen inside. Now, what is the site of origin? Here is the right ovary, so it is left ovarian. This is the right ovary, and the right ovary show here a follicle. This is a dominant follicle, not a lesion. But take care to see that if there is no enhancing lesions inside on the post-contrast study, because it may be bilateral, and this is just a smaller one of the large entity. Another sign that the adnexal region here is pulled towards this mass, pulled up towards this mass, and this is another sign. The ovarian vein is pulled also up towards the mass, and this is a sign that it is ovarian in nature, in origin. Another case, this is the ovary, this is the ovarian stroma, and this is the antral follicles present in the ovary. We stated before what is the antral follicles present in the ovary. They are in the background of the ovary, less than 10 millimeter each. And then coming this mass arising from one of the follicles. It is a germ cell. If we return back to the figure seen before, here, it is arising from the follicle. So it is a germ cell tumor. So this one is a germ cell tumor. So here, I didn't just say that it is ovarian. No, it is ovarian because there is peak sign, and it is germ cell tumor because it is arising from the follicle inside the ovary. So it's very nice. In this case, it was bilateral. It was a young girl. It was bilateral, and there was a very large mass in the other side. But this smaller one indicate bilaterality of the lesion, and it was a case of this germinoma, and there was ascites also here, and there was para-aortic lymph nodes. Many of the findings was in this case. Again, site of origin, ovarian or not. Here we have a complex cystic lesions with multiple papillae, very much simulating the serous or mucinous cyst adenoma. في multiple papillary here, so it's very much mimicking the ovarian lesion. But on reviewing the different images, we find that the normal ovary is seen separable from this mass. So it is not ovarian. And the pathology was peritoneal cyst, mucinous cyst adenoma. It was peritoneal mucinous cyst adenoma, one of the differential diagnoses we mentioned in the adnexal region. And here is a dominant follicle in the ovary. This ovary is completely normal. So it's not ovarian, it is peritoneal in origin. So always search if there is normal ovary present or not. In solid adnexal masses, we have different signs to describe is this ovarian or it is uterine or otherwise. If it is ovarian, we have a peak sign. The ovarian tissue is seen peaking around this lesion. So this is what is called the peak sign. The ovary with its follicles peaking around the lesion, and the peak sign is usually not in 100% of cases, is usually seen with benign lesions rather than malignant lesions. The claw sign is seen with the uterus when the myometrium is seen peaking around the lesion in subserous fibroids. So this is the claw sign. And we have bridging vascular sign. This is the bridging vessels seen in cases of subserous fibroid or pedunculated subserous fibroid. This is what is called the bridging vessel sign. This is another sign to ensure that it is uterine in origin. And this case was a fetal MRI and patient presenting with epigastric pain, and this mass was seen. Many of those who see the case say that it may be ovarian, but it's not ovarian. It is upping the uterus. There is vascular bridging sign, and there is not claw sign very much, but it's related to the uterus. So this is a degenerated fibroid, red degeneration in a fibroid, although late. It was late in pregnancy, but it is a red degeneration in a fibroid. MRI imaging of ovarian masses. We have conventional imaging, axial T1, sagittal axial oblique coronal T2, because the T2 is the sequence that we can see the anatomy. T1 fat suppression. This is the conventional imaging that we use in the MRI characterization function. When we want characterization of a lesion, we do conventional imaging. We have not to proceed to the functional imaging. But when we think of neoplastic lesion, then we go to the functional imaging, dynamic contrast enhanced MRI, diffusion weighted MRI, and MRS, which is tedious and long procedure, and so it is not frequently done. But you have to know what is the chemicals that increase in cases of ovarian malignancy. Then back to interpretation of the images. When you have an MRI, how to interpret the images. Conventional images in the adnexal masses, the first description is to say, is this tumor cystic, solid, or mixed? Usually, many of my students say first, ill-defined or well-defined. I think most lesions of the ovary are well-defined, except if it is inflammatory and not so obvious. But all lesions are well-defined. Better to say, is it cystic, solid, or mixed? So this is an adnexal mass, so, predominantly solid in nature. The origin, yes, this is the ovary, and it arises exophytic from the surface epithelium of the ovary. It arises here, exophytic from the surface epithelium of the ovary. This is regarding the primary, we know the origin. It is arising from the surface of the ovary. It is predominantly solid, and there is secondary signs, there is ascites. So this is the first description of this lesion. It is predominantly solid, arising from the surface of the ovary. Next, here, this is another case. This is the T1 post-contrast because the uterus is enhancing here. This is the uterus being retroflexed. It is retroflexed because this mass is pushing the uterus to the back. So it is retroflexed. This is anechoic cystic structure present here. Anechoic cystic structure or hypointense. Hypointense, it's like the urinary bladder. So here from the T1, we can detect the characterization that it is fluid in nature. It is fluid in nature. From where it arises, and this is the T2, it is bright in T2, and there is another here lesion in the other side with ovarian peaking around. This is ovarian peaking. So this is another cystic lesion. So it is bilateral. So it is bilateral. So it is low in T1, high in T2. Here, the ovarian peak sign, and this is the uterus. So this is a serous cystadenoma bilateral. Appearance of the tumor, involvement of one or both ovaries. Bilaterality is very important in ovarian lesions. It is bilateral in 25 to 40% according to the tumor type, 80% in Krukenberg tumor as we stated before. التكرار يعلم الشطار. Okay, يبقى this lesion, we have bilateral enlarged ovaries. This is multicystic ovaries. There is multiple follicles, and the ovarian stroma is abundant. And this, what we see usually in hyperstimulation or hormonal problems. And this is the other ovary. This is multicystic ovary. So is it neoplastic or not? I see that it was not neoplastic. This patient was 28 years old. I think you will find on the group. She was 28 years old. She has menstrual irregularities and was on hormonal treatment. This was not clearly stated in her first visit, and so many thought that it may be stromal tumor or something malignant, but it is not malignant. It is one of the functional ovarian masses. This is a functional ovarian mass, and the patient stay on hormonal treatment with follow-up. The signal intensity of the lesion, again to this case, here the signal intensity is hypointense or isointense في T2 وhypointense في T1. Enhancement, the enhancement and wall thickness. Here there is thickened wall and there is enhancing septi with solid parts. This was a case of immature teratoma, and sometimes the immature teratoma is better detected on CT than MRI. So we have to comment on the enhancement and on the wall thickness. Presence of vegetations. This was a case 24 years old. She has enhancing vegetations, as you see here, bilateral. Note here, you know the first case that I see a cyst, but take care, there is an enhancing vegetation here also, so it is bilateral. So here, this was a case of borderline papillary serous cyst adenoma, bilateral. So bilaterality is very important. And there is ovarian peaking around here in the smaller one. So when you find an ovarian mass, take care to look on the other ovary. Then the presence of secondary signs, presence of ascites, presence of peritoneal and omental deposits, and usually the peritoneal and omental deposits are similar to the mother tumor. Here, this is the mass, and here there is an implant in the Douglas pouch, cystic and solid like the primary tumor. If you have the primary tumor mainly solid, you will find peritoneal implants solid in nature. So this is the secondary signs, and don't miss to search on lymph nodes and on the other pelvic organs. If it is infiltrating the bowel, this is very important. The posterior wall of the urinary bladder, so you have to comment on the other pelvic organs. Regarding benign ovarian tumors, mature cystic teratoma is the most common in the age of 20 to 40 years, accounting for 10 to 20% of all ovarian neoplastic lesions. Then came the stromal cell tumor, fibroma and fibrothecoma, and then the cyst adenomas, epithelial tumors of the ovary. MRI regarding the mature cystic teratoma, and we have a lecture completed على الماتيور cystic teratoma. الفات component تبقى bright in T1. Here we have bilateral mature cystic teratoma. Here is bilateral mature cystic teratoma. This is bright in T1 and suppressed on fat suppression, but this cystic component, it's not fat. And here also there is a part that is suppressed in this image. So this is T1 fat suppression, and T2. So in this case, it is sure case of mature cystic teratoma. And please, when you write in the conclusion, don't write likely. The MRI is the diagnostic in these cases, so don't write likely. It is ovarian and it is mature cystic teratoma, so don't write likely. Fat component bright in T1 and T2, suppressed on fat suppression. Another case, if you find a minority of fat, then also it is teratoma. A minority of mature cystic teratoma will demonstrate a sebum-filled cystic cavity. All this sebum, it's not suppressed on fat suppression. And there is only one fat globule here. This is a small fat globule here. So this is mature cystic teratoma also. Because in the mature cystic teratoma, we have a variety of tissues present. So only evidence of fat in the wall or in the Rokitansky nodule, it is also mature cystic teratoma. Intracystic non-dependent spheres of lipid material can occasionally be identified in a mature cystic teratoma, produce this striking appearance. So this is again mature cystic teratoma. One of the MRI merits in the characterization of ovarian masses in T2 is the ovarian fibroma, low signal on T2. Ovarian fibroma, it is low signal on T2. You have just to differentiate it from the subserous fibroid. If you search is the ovary present or not, if there is close sign with the uterus bridging vessels, so this is a case of ovarian fibroma. Fibrothecoma, this is a fibrothecoma group. Fibroma, fibrothecoma. Fibrothecoma, sometimes it has central, this fibrothecoma, this was a calcification inside the cyst, inside this mass. So again, low signal of the majority in T2 can diagnose fibrothecoma. Cyst adenofibroma. Cyst adenofibroma is a rare tumor, but it can be diagnosed by its low T2 signal in the part of the solid component. This is complex cystic and solid, and this is the solid part is hypo-intense, similar to muscle and similar to the myometrium. It is hypo-intense in T2, of low signal in T2, so this is the appearance of cyst adenofibroma. And it's very important to diagnose a benign lesion versus malignant lesion. So this is a cyst adenofibroma. Another case, this is Brenner tumor. It is low T2 signal, but sometimes the Brenner tumor, it has a spectrum. A very small percent of the Brenner tumor may be malignant. So fibroma, fibrothecoma, cyst adenofibroma, and Brenner tumor. This is benign cyst adenomas. We say the most common, the mature cystic teratoma, and then the ovarian fibroma and fibrothecoma group, and the cyst adenofibroma and Brenner tumor. And then the benign cyst adenomas, we have the mucinous type. This is the bright T2 signal, please. Bright T2 signal or iso-intense signal in T1. This is not blood nor fat. It is just a proteinaceous or mucinous type of tumor. This is mucin. Note the difference between it and the fat and the endometrioma we have seen before. So this signal is not of blood nor fat. It is just mucinous type of cyst adenoma. Thin septations less than 3 millimeters, solid vegetations less than 7 millimeters. So this is a benign cyst adenoma. في mucinous type or serous type according to the signal intensity seen on MRI. The MRI criteria in detection of malignancy, we have primary signs and secondary signs. Primary signs regarding the mass size, but not so specific, because the most ovarian tumor that cause a very large size is the serous cyst adenoma. Bilaterality, more with benign malignant lesions, except for the papillary serous cyst adenoma, which is bilateral in 40% of cases. Mass predominantly solid, except for the solid benign lesions. The most common is the ovarian fibroma. Necrosis in a solid lesion. Cystic lesion with wall or septal thickness more than 3 millimeters, and this will we will get to the category of either borderline or malignant tumor. Papillary projections. And then if there is secondary signs, that we are talking about malignant lesions. Ascites, except also in ovarian fibroma, because in ovarian fibroma there is Meigs syndrome, which cause ascites and pleural effusion. So again, take care. If we find low signal in the T2, then it is fibroma. Peritoneal metastasis, if the presence of peritoneal metastasis, and here we will have the question, is it primary ovarian malignancy or Krukenberg tumor due to metastasis from other intra-abdominal organ. Lymphadenopathy, we have to search about the first station. In ovarian, the first station is the para-aortic lymph nodes. This is a right ovarian mass in a patient 60 years old female. Here we have to answer all the points that we have said. Regarding the origin, this is a large pelvic abdominal mass. What is the origin? It's ovarian. Why? Because this is the uterus, and here is the ligament. And note here that the adnexal lesion with the ligament is trapped or pulled up towards this mass. Although there is no peak sign, because this lesion is mostly malignant, so there is no peak sign of the ovary, but we can know that it is ovarian by this traction on the adnexal region. This mass, solid, cystic, or complex, it is complex mass with solid component, thick septi, thick enhancing septi, so it is towards malignancy more. Then we have to answer unilateral or bilateral. This is the traction on the lesion, and the ovarian vein is pushed up with the mass. And then we have here the other ovary. although she is postmenopausal, but we can see the ovary by its landmark. Here is the ovary. There is few follicles inside, or يعني not follicle because this is T2. And this is the ovary. It is ellipsoid in shape or almond shape, and here the internal iliac vessels is seen lateral to it. So this is the anatomical landmark of the ovary. So it is unilateral. Of course, in this age, it's not so significant to say it's unilateral or bilateral, because usually in these patients they do panhysterectomy, but it will be more specific if we have borderline tumor in childbearing age and we need to preserve the fertility for this lady. And then we came to the staging of the ovarian lesions, and usually the staging of ovarian lesions is misleaded, because here in stage 1A, the tumor localized one ovary and the capsule is intact. 1B, both ovaries and the capsule is intact. Malignant cells in the ascites, this is a surgical staging. They do surgical staging by knowing if there is a whoosh, if there is malignant cells in the peritoneum or not. If it is disrupting the capsule, so it is 1C. Stage 2A, and here is usually we report this stage not correctly, because if there is infiltration of anything in the vicinity of the pelvis, it is stage 2. If it is in the vicinity of the pelvis, we can do debulking of the whole tumor, so it is stage 2. 2A, if it is reaching the fallopian tube or reaching the uterus. 2B, if it is infiltrating even the urinary bladder, we can manage it as 2B. Infiltration of the tumor to the rectum also can be managed. Stage 3, spread to the tumor to the retroperitoneal lymph nodes. If it is spread to the pelvic lymph nodes only, so this is 3A. If it's spread to the para-aortic lymph node, it is 3B. If there is peritoneal deposits also, if it is pelvic, it is stage 3. If it reach upwards to the abdominal, it is stage 4. Or stage 4 by the presence of pleural effusion, lung metastasis, and others. This is stage 4. In the staging of the ovarian tumors, PET scan is the best. PET scan is the best in these cases, except for the pitfalls of very small implant, or sometimes in PET scan you see that the peritoneal itself is enhancing on PET CT. Means that there may be tumor cells present in the peritoneum. This is a case. Here we have a complex solid and cystic lesion, and this complex solid and cystic lesion is infiltrating the fallopian tube. This is the fallopian tube, and there is a mass inside. Remember the last lecture we say that the mass in the fallopian tube is mostly metastatic from genital organs. And then we have also infiltration of the uterus by this mass. This is infiltration of the myometrium. This is the rectum. There is here narrowing, but I couldn't delineate if there is infiltration of this part or not. We have to see in different planes, but what was so obvious here is the infiltration of the fallopian tube and infiltration of the uterus. So it is stage 2A. Then we have also the borderline ovarian tumors. Borderline ovarian tumors is a diagnostic dilemma ranging from 15 to 20% of the ovarian epithelial tumors. Borderline ovarian tumors are histologically characterized as epithelial tumors with stratified growth, but without destructive stromal invasion. So in most of these cases, there is no metastasis, but they are liable to local recurrence. Serous and mucinous neoplastic lesions are the majority of these borderline ovarian tumors, occurring mostly in women in the reproductive age, and this is very important because we have to spare the fertility in these cases. The most important role of functional MRI in these cases. Dynamic post-contrast MRI, and this is the dynamic post-contrast MRI. See here, we take sequences like we do in the MRI breast. We take pre and post-contrast sequence and we see the pattern of enhancement. You see here there is early enhancement and there is washout in the delayed film, so this is with malignant lesion. And we can show a curve. You see here the region of interest is applied to the areas of maximum enhancement and the behavior of contrast intake on this graph. And we here have the parameters of evaluation, the enhancement amplitude, the maximum relative enhancement percent, and all this is written in the table of measurements. The enhancement amplitude, maximum relative enhancement, and this was done by Dr. Sahar Mansour in 2015. If the enhancement more than 120%, so it is with malignancy. If it is less than 120%, it is with benignity. At time of the initial peak of the maximum uptake, if it takes early enhancement less than or equal 120 seconds, then this is with malignancy. If it is more than 200, then it is delayed. Maximum slope of enhancement, the slope of enhancement, continuous rise, this is type 1 curve, which is benign. Plateau curve, this is the borderline, but usually you compare with the morphological findings of the ovarian lesion. And early washout, this is with malignancy, type 3 curve. This is the 3 types of curve, type 1, type 2, and type 3. But we have to weigh the findings, the morphological findings with the functional findings regarding the dynamic MRI with diffusion weighted images. This is a case. She was a female patient, 15 years old, and coming with this adnexal mass, likely ovarian in nature, with multiple papillary projections inside, enhancing. But what is the pattern of this enhancement? And this is the other ovary, so it is on the right side. So we have right ovarian mass with solid papillary projections, enhancing on the post-contrast study. So we have solid component and cystic component. Is it malignant, borderline, or benign? We have to go to the functional imaging. So here, this is the time to peak, about 200. So there is no rapid enhancement. Here is the maximum enhancement, 142, and the type curve is rising curve. So this is a benign looking lesion on dynamic contrast enhanced MRI. There was diffusion, but I don't know where it came. There was diffusion image, and there was no restriction on diffusion, and the MRS was done also in this case, and it was with benignity. Regarding the diffusion weighted MRI, it is a functional imaging technique that displays information about the water mobility, tissue cellularity, and the integrity of the cell membrane. Here, this is increased cellularity, which causes restriction, and this is decreased cellularity that causes facilitated diffusion. The p-value refers to the strength of the diffusion sensitizing gradients. Usually when you try to look on the high p-value, because the high p-value is more specific to the malignant lesions on restriction. Qualitatively, regarding the signal, restricted diffusion, we have increased the signal intensity increase on diffusion weighted image and decrease on the ADC map. Quantitatively, regarding the ADC value, the ADC map generated from the different p-values. ROA measured manually over the largest possible area from solid and cystic component. and we select an area from solid and cystic component, and we try to measure the ADC value. If the ADC value is more than or equal 1.25, then it is with benignity more than malignancy. What is the applications of the use of diffusion weighted image? To start to say that diffusion weighted image is a simple sequence that take short time. So please put it in all protocols of your ovarian lesions. But it will show false positive results with mature cystic teratoma and with endometrioma. But otherwise, you can detect the malignant lesion. For characterization of the primary lesion, if the primary lesion is restricted on the diffusion weighted and low on the ADC map, so it is likely malignant lesion. And also in the presence of peritoneal deposits or lymph nodes. Look for this small peritoneal implant. I think it will be missed if you didn't look on the diffusion weighted image. It is bright on the diffusion and low in the ADC map, so it is a peritoneal implant, although it is very small in size. So in all cases, if you are searching about peritoneal implants, please look on the diffusion weighted images. For lymph node assessment, sometimes you find a small lymph node, and when you find it restricted in diffusion, you will highlight that. And here the lymph node also lacking the, although it is subcentimetric or small in size, but it is likely infiltrated because the fatty hilum is not preserved and it is restricted in diffusion, so it warrants to be mentioned in your report. Differentiating residual and recurrent tumor in the post-operative change, and this is very important. Sometimes patient after surgery coming back for assessment. Sometimes there is fibrosis because these patients may take post-operative radiation or post-operative chemotherapy causing fibrotic changes in the pelvis. So this area we couldn't know is it something or not. But on diffusion weighted image, it is not restricted, so it is nothing. It's just a fibrous tissue. This is a case of granulosa cell tumor. Note here, it is high signal on diffusion weighted image and low signal on the ADC map with ADC value of 0.68. So all this fitting with malignant lesion. This is another case. Serous cyst adenoma with papillary projections inside. It is high signal on diffusion and high signal on the ADC map, which we say it is T2 shine through. Well, ADC value 2, so it is benign lesion. This is a case of ovarian fibroma. Here, no abnormal high signal on diffusion weighted image, and it is high on the ADC map, high ADC value. But in case of ovarian fibroma, sometimes if it is highly cellular, it can cause restricted diffusion also. Here also we have a papillary cyst adenoma with restriction in the papillary present and the criteria fitting with malignant lesion. But this case, here the ADC was 1, not more than 1.2, yani it's relatively high with this enhancement. Here there is faint enhancement matching with benignity more than malignancy. So this is a case of borderline ovarian tumor. Borderline serous cyst adenoma. But take care, not all restricted masses malignant. Findings in benign ovarian lesions, مين هما بقى benign ovarian lesions that cause restricted diffusion? Teratoma, variable heterogeneous, high for T1 but low on T1 fat suppression, but sometimes it causes restricted diffusion due to heterogeneity of the contents and the presence of Rickettiniski nodules. Hemorrhagic cyst high to intermediate, low in chronic hemorrhage, تبقى high في T1. Usually it is not restricted, and many papers say that we can differentiate hemorrhagic cyst from endometrioma by the pattern of restriction. Endometrioma, it shows different signal intensity. We have seen in the cases of endometriomas previously put in the lecture. But they are, most of cases show restricted diffusion. It's high and low, showing restricted diffusion. Ovarian torsion, it is high in T2 due to the edema present, high in T1, and it is high in the restriction. It is restricted on diffusion due to the presence of sometimes impending infarction due to the edema present, so it causes restricted diffusion. Tubo-ovarian abscess is variable and heterogeneous and also cause restricted diffusion on imaging due to the presence of pus inside. Functional thecoma and cellular fibroma can cause also restricted diffusion. Moreover, more than all these, the normal ovary sometimes show restricted diffusion. Then we came to the last functional imaging modality in MRI is the MR spectroscopy. We will not go deep through because it's not common procedure to be done. It showed significant increase in the lactate and alanine peaks and low glucose in malignant lesions. But in benign lesions, the absence of lactate is a good indicator that the lesion is benign. Absence of lactate peak is very important. If you find absence of lactate peak, so you are you are talking about benign lesion. Of course, with the other criterion, this is the case I have told you about. Here, there is absent lactate peak, and being absent lactate peak, so this is a borderline ovarian tumor. Here we are taking on the nodule present or the vegetation present inside the cyst. So to sum up, ovarian lesions detected by ultrasound, if they are functional cysts less than or equal 5 centimeter, please don't do another imaging modality. Just repeat follow-up ultrasound. If it is complicated or increase in size, we can go to MRI. In ovarian lesions detected by ultrasound, if they are complex cystic with no solid parts, then we need Doppler, very important, no vascularity on Doppler. Then we need MRI for characterization, T1, T2, and fat suppression. If we have complex cystic and solid, MRI for staging, T1, T2, fat suppression, and post-contrast, then go to diffusion-weighted images and post-contrast study functional MRI. If it is purely solid, we can just look on T2. If it is low in T2, then it is benign. If it is high in T2, then we have to go through all functional modalities, dynamic, diffusion, and MRS if we can do it. So what is the role of CT? We are talking about the cross-sectional imaging. What is the role of CT? CT is not the modality of choice in adnexal lesions, except in teratoma. In teratoma here this is a case of teratoma. It is complex adnexal mass showing fat, showing cystic component like the urinary bladder, showing a tooth, and there is no enhancing lesions inside this cyst. Here, this is the enhancing myometrium. There is no enhancing lesions here. This is what to search on when you do CT for mature cystic teratoma. And pelvic mass of enteric origin. If we suspect that this patient may have something related to the bowel, better to do CT or CT enterography, we can do it. This case, she has an adnexal lesion with blurring of the fat planes, and we thought that it may be tubo-ovarian abscess if we have just look on this cut. But when you see the other the abdomen, you found that this is the concertina pattern of the sigmoid colon, and we have multiple diverticuli, and this is a peridiverticular abscess. Standard CT also is useful in determining the extent of disease. If we have a known case that is malignant, primary and secondary signs, We have here a case of bilateral adnexal masses, thick septi, solid component, thick wall, all their criteria of malignancy we have seen. And this is the uterus enhancing inside, this is the endometrium, and this is the enhancing myometrium. And we have other signs of malignancy. We have peritoneal implant. We have, in this case, in the upper cuts, there was a scalloping of the liver border, so it is sure malignant. So we can do CT in this case to determine the tumor resectability, to see its effect on the bowel, and to detect metastatic lesions. Peritoneal metastasis being sometimes the first presentation, CT frequently fail to identify small sites of peritoneal spread. So what to do? The better that we have said from a while is the PET CT. In premenopausal women, the amount of uptake in the ovaries varies according to the phase of the menstrual cycle. If the patient was coming during the second half of the menstrual cycle, you will find this enhancing lesion, which is the corpus luteum cyst of the ovary. And when you go to the reference of CT, you will find a small cyst in the ovary. Here, this is a corpus luteum cyst. The typical appearance of physiological uptake is this spherical or discoid, smooth, with the smooth margins located above the urinary bladder or around the uterus. This is very important. But in postmenopausal women, it is not acceptable to find an ovarian uptake. And this is primary ovarian malignancy with the omental cake we used to see, and this is how it take on MRI. And here there is another implant here, was not seen on the reference image. So take home message, non-neoplastic lesions should always be taken into consideration. And they are the most common. 90% of the ovarian lesions will subside and go away during, especially in the young age group. Teenager and the 20s, please give their time. In endometriosis, the presence of complex and rapidly growing mass with contrast enhancement may raise the suspicion of endometrioid or clear cell carcinoma, and these cases necessitating to do contrast enhanced MRI. A very low signal on T2 image indicates a fibrotic component suggesting a tumor of the coma fibroma group, cystadenophibroma or Brenner tumor. Sequences with fat saturation are helpful when facing a mass with high signal on T1 weighted image. عشان كده بنعمل T1 fat suppression is one of the established in the protocol of the ovarian lesions. Not all high signal on T1 blood or fat. A stained glass appearance with cystic loculi of variable signal intensity may refer to a mucinous ovarian tumor. Last home message, last but not least, functional MRI is mandatory in borderline ovarian tumors and in staging malignant ones. Thank you.